Good morning. This is Amy from Good Food on Earth. And as many of you are aware of, currently we have 24/7 news reporting on the coronavirus pandemic. And there's some information I'd like to share with you from 22 different medical experts around the world who question the extreme measures, as I do, about that are being taken by governments with regards to the coronavirus. And this is based on their research, and I'd like to just share what they have said, and I will leave it up to you to decide what you want from this. We'll start with Dr. Sucharit Bhakdi. He is a specialist in microbiology. He was a professor at Johannes Gutenberg University in Mainz and head of the Institute for Medical Microbiology and Hygiene, and one of the most cited research scientists in German history. What he says: "We are afraid that 1 million infections with the new virus will lead to 30 deaths per day over the next 100 days, but we do not realize that 20, 30, 40, or 100 patients positive for normal coronaviruses are already dying every day. The government's anti-COVID-19 measures are grotesque, absurd, and very dangerous. The life expectancy of millions is being shortened. The horrifying impact on the world economy threatens the existence of countless people. The consequences on medical care are profound. Already, services to patients in need are reduced, operations canceled, practices empty, hospital personnel dwindling. All this will impact profoundly on our whole society. All these measures are leading to self-destruction and collective suicide based on nothing but a spook." Dr. Wolfgang Wodarg is a German physician specializing in pulmonology, politician, and former chairman of the Parliamentary Assembly of the Council of Europe. In 2009, he called for an inquiry into the alleged conflicts of interest surrounding the EU response to the swine flu pandemic. What he says: "Politicians are being courted by scientists who want to be important, to get money for their institutions, scientists who just swim along in the mainstream and want their part of it. And what is missing right now is a rational way of looking at things. We should be asking questions like, how did you find out this virus was dangerous? How was it before? Didn't we have the same thing last year? Is it even something new? That's missing." Dr. Joel Kettner, professor of community health sciences and surgery at Manitoba University, former chief public health officer for Manitoba province, and medical director of the International Center for Infectious Diseases. What he says: "I have never seen anything like this, anything anywhere near like this. I'm not talking about the pandemic, because I've seen 30 of them, one every year. It's called influenza. And other respiratory illness viruses, we don't always know what they are. But I've never seen this reaction, and I'm trying to understand why. I worry about the message to the public, about the fear of coming into contact with people, being in the same space as people, shaking their hands, having meetings with people. I worry about many, many consequences related to that. In Hubei, the province of Hubei, where there has been the most cases and deaths by far, the actual number of cases reported is 1 per 1,000 people, and the actual rate of deaths reported is 1 per 20,000. So maybe that would help to put things into perspective. Dr. Ioannidis, professor of medicine, of health research and policy, and of Biomedical Data Science at Stanford University School of Medicine, and a professor of statistics at Stanford University School of Humanities and Sciences. He is a director of the Stanford Prevention Research Center and co-director of the Meta Research Innovation Center at Stanford. He is also the editor-in-chief of the European Journal of Clinical Investigation. He was chairman at the Department of Hygiene and Epidemiology, University of Ioannidis School of Medicine, as well as adjunct professor at Tufts University School of Medicine. As a physician, scientist, and author, he has made contributions to evidence-based medicine, epidemiology, data science, and clinical research. In addition, he pioneered the field of meta-research. He has shown that much of the published research does not meet good scientific standards of evidence. What he says: patients who have been tested for SARS-CoV-2 are disproportionately those with severe symptoms and bad outcomes. As most health symptoms have limited testing capacity, selection bias may even worsen in the near future. The one situation where an entire closed population was tested was the Diamond Princess cruise ship and its quarantined passengers. The case fatality rate there was 1%, but this was a largely elderly population in which the death rate from COVID-19 is much higher. Could the COVID-19 case fatality rate be that low? No, some say, pointing to the high rate in elderly people. However, even some so-called mild or common cold type coronaviruses that have been known for decades can have case fatality rates as high as 8% when they infect elderly people in nursing homes. If we had not known about a new virus out there and had not checked individuals with PCR tests, the number of total deaths due to influenza-like illness would not seem unusual this year. At most, we might have casually noted that this flu season seems to be a bit worse than average. Dr. Yoram Loss is an Israeli physician, politician, and former Director General of the Health Ministry. He also worked as Associate Dean of the Tel Aviv University Medical School, and during the 1980s presented the science-based television show Tatzpit. What he says: Italy is known for its enormous morbidity in respiratory problems, more than 3 times any other European country. In the US, about 40,000 people die in a regular flu season, and so far, 40 to 50 people have died of the coronavirus. Most of them in a nursing home in Kirkland, Washington. In every country, more people die from regular flu compared with those who die from the coronavirus. There is a very good example that we all forget: the swine flu in 2009. That was a virus that reached the world from Mexico, and until today, there is no vaccination against it. But what? At that time, there was no Facebook, and there maybe was, but it was still in its infancy. The coronavirus, in contrast, is a virus with public relations. Whoever thinks that governments end viruses is wrong. Dr. Pietro Vernazza is a Swiss physician specializing in infectious diseases at the Cantonal Hospital St. Gallen and professor of health policy. What he says: we have reliable figures from Italy and a work by epidemiologists, which has been published in the renowned science journal Science, which examined the spread in China. This makes it clear that around 85% of all infections have occurred without anyone noticing the infection. 90% of the diseased patients are verifiably over 70 years old, 50% over 80 years. In Italy, 1 in 10 people diagnosed die, according to the findings of a science publication. That is statistically 1 of every 1,000 people infected. Each individual case is tragic, but often, similar to the flu season, it affects people who are at the end of their lives. If we close the schools, we will prevent children from quickly becoming immune. We should better integrate the scientific facts into the political decisions. Frank Ulrich Montgomery is a German radiologist, former president of the German Medical Association and deputy chairman of the World Medical Association. What he says: "I'm not a fan of lockdown. Anyone who imposes something like this must also say when and how to pick it up again. Since we have to assume that the virus will be with us for a long time, I wonder when we will return to normal. You can't keep schools and daycare centers closed until the end of the year, because it will take at least that long until we have a vaccine." Italy has imposed a lockdown and has the opposite effect. They quickly reached their capacity limits, but did not slow the virus spread within the lockdown. Professor Hendrik Streeck is a German HIV researcher, epidemiologist, and clinical trialist. He is professor of virology and the director of the Institute of Virology and HIV Research at Bonn University. What he says: "The new pathogen is not that dangerous. It is even less dangerous than SARS-1. The special thing is that SARS-CoV-2 replicates in the upper throat area and is therefore much more infectious because the virus jumps from throat to throat, so to speak. But that is also an advantage. Because SARS-1 replicates in the deep lungs, it is not so infectious, but it definitely gets on the lungs, which makes it more dangerous. You also have to take into account that the SARS-CoV-2 deaths in Germany were exclusively old people. In Heinsberg, for example, a 78-year-old man with previous illnesses died of heart failure, and that without SARS-2 lung involvement. Since he was infected, he naturally appears in the COVID-19 statistics. But the question is whether he would not have died anyway, without SARS-2. Dr. Ioannidis Roussel et al., a team of researchers from the Institut Hospitalo-Universitaire Méditerranée Infection, Marseille, and the Institut de Recherche pour le Développement, conducting a peer-reviewed study on coronavirus mortality for the government of France under the Investments for the Future program. Here's what they say. The problem of SARS-CoV-2 is probably overestimated, as 2.6 million people die of respiratory infections each year, compared with less than 4,000 deaths from SARS-CoV-2 at the time of writing. This study compared the mortality rate of SARS-CoV-2 in OECD countries, 1.3%, with the mortality rate of common coronaviruses identified in APHM patients, 0.8%, from 1st January 2013 to 2nd March 2020. Chi-squared test was performed and the p-value was 0.11, not significant. It should be noted that systematic studies of other coronaviruses, but not yet for SARS-CoV-2, have found that the percentage of asymptomatic carriers is equal to or even higher than the percentage of symptomatic patients. The same data for SARS-CoV-2 may soon be available, which will further reduce the relative risk associated with this specific pathology. That was as of 19th of March, 2020. Dr. David Katz, an American physician and founding director of the Yale University Prevention Research Center. What he says: I am deeply concerned that the social, economic, and public health consequences of this near total meltdown of normal life, schools and businesses closed, gatherings banned, will be long-lasting and calamitous, possibly graver than the direct toll of the virus itself. The stock market will bounce back in time, but many businesses never will. The unemployment, impoverishment, and despair likely to result will be public health scourges of the first order. Michael T. Osterholm is Regents Professor and the Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. What he says: consider the effect of shutting down offices, schools, transportation systems, restaurants, hotels, theaters, concert halls, sporting events, and other venues indefinitely, and leaving all of their workers unemployed and on the public dole. The likely result would be not just a depression, but a complete economic breakdown, with countless permanently lost jobs, long before a vaccine is ready or natural immunity takes hold. The best alternative will probably entail letting those at low risk for serious disease continue to work, keep business and manufacturing operating, and run society, while at the same time advising higher risk individuals to protect themselves through physical distancing and ramping up our healthcare capacity as aggressively as possible. With this battle plan, we could gradually build up immunity without destroying the financial structure on which our lives are based. It's from the Washington Post, 21st of March. Dr. Peter Gertscha, a professor of clinical research design and analysis at the University of Copenhagen and founder of the Cochrane Medical Collaboration. He's written several books on corruption in the field of medicine and the power of big pharmaceutical companies. Here's what he says: our main problem is that no one will ever get in trouble for measures that are too draconian. They will only get in trouble if they do too little. So our politicians and those working with public health do much more than they should do. No such draconian measures were applied during the 2009 influenza pandemic, and they obviously cannot be applied every winter, which is all year round, as it is always winter somewhere. We cannot close down the whole world permanently. Should it turn out that the epidemic wanes before long, there will be a queue of people wanting to take credit for this. And we can be damn sure draconian measures will be applied again next time. But remember the joke about tigers. Why do you blow the horn? To keep the tigers away. But there are no tigers. There, you see? It's from March 21st. Dr. Sucharit Gupta et al. Are an Oxford-based research team constructing an epidemiological model for the coronavirus outbreak. Their paper has yet to be peer-reviewed, but the abstract is available online. Dr. Gupta is a professor of theoretical epidemiology at the University of Oxford with an interest in infectious disease agents that are responsible for malaria, HIV, influenza, and bacterial meningitis. She is a recipient of the Sahitya Akademi Award, the Scientific Medal by the Zoological Society of London, and the Royal Society Rosalind Franklin Award for her scientific research. Here's what her team says. Importantly, the research we present here suggests the ongoing epidemics in the UK and Italy started at least a month before the first reported death and have already led to the accumulation of significant levels of herd immunity in both countries. There is an inverse relationship between the proportion currently immune and the fraction of the population vulnerable to severe disease. The research presents a very different view of the epidemic to the modeling at Imperial College London. I'm surprised that there has been such unqualified acceptance of the imperial model, Dr. Gupta said. The Oxford results would mean the country had already acquired substantial herd immunity through the unrecognized spread of COVID-19 over more than 2 months. Although some experts have shed doubt on the strength and length of the human immune response to the virus, Professor Gupta said the emerging evidence made her confident that humanity would build up herd immunity against COVID-19. Dr. Karen Mulling is a German virologist whose research focused on retroviruses, particularly human immunodeficiency virus. She was a full professor and director of the Institute of Medical Virology at the University of Zurich from 1993 until her retirement in 2008, and received multiple honors and awards for her work. Here's what she says. You are now told every morning how many SARS-CoV-2 deaths there are. But they don't tell you how many people already are infected with influenza this year and how many deaths it has caused. This winter, the flu is not severe, but around 80,000 are infected. You don't get these numbers at all. Something similar occurred 2 years ago. This is not put into the right context. Every week, a person dies in Berlin from multi-resistant germs. That adds up to 35,000 a year in Germany. This is not mentioned at all. I believe that we have had situations like this several times, and that the measures are now being taken too far. I am of the opinion that maybe one should not do so much against young people having parties together and infecting each other. We have to build immunity somehow. How can that be possible without contacts? The younger ones handle the infection much better. But we have to protect the elderly and protect them in a way that can be scrutinized. Is it reasonable what we are doing now to stretch out the epidemic in a way that almost paralyzes the entire world economy? The Robert Koch Institute provides the figures. Then you sit there as a listener or spectator. 20 dead again. How terrible. Do you know when I would start to panic? If there are 20,000. Then we get close to what went on completely quietly 2 years ago. The 2018 influenza epidemic with 25,000 deaths never disconcerted the press. The clinics had to deal with the additional 60,000 patients, which was no problem in the clinics either. That is the main fear. The disease is presented as a terrible disease. The disease per se is like the flu in a normal winter. It is even weaker in the first week. That's from the 23rd of March, 2020. Dr. Anders Tegnell is a Swedish physician and civil servant who has been state epidemiologist of the Public Health Agency of Sweden since 2013. Dr. Tegnell graduated from medical school in 1985, specializing in infectious disease. He later obtained a PhD in medical science from Linköping University in 2003 and a Master's of Science in 2004. And here's what he says. All measures that we take must be feasible over a longer period of time. Otherwise, the population will lose acceptance of the entire corona strategy. Older people or people with previous health problems should be isolated as much as possible. So no visits to children or grandchildren, no journeys by public transport, if possible, no shopping. That is the one rule. The other is, anyone with symptoms should stay at home immediately, even with the slightest cough. If you follow these two rules, you don't need any further measures, the effect of which is only very marginal anyway. Dr. Pablo Goldschmidt is an Argentine-French virologist specializing in tropical diseases and professor of molecular pharmacology at the Université Pierre et Marie Curie in Paris. He is a graduate of the Faculty of Pharmacy and Biochemistry of the University of Buenos Aires and Faculty of Medicine at the Hospital Center of Pitié-Salpêtrière, Paris. He currently resides in France, where he has worked for almost 40 years as a researcher in clinical laboratories, developing diagnostic technology. And here's what he says. The ill-founded opinions expressed by international experts, replicated by the media and social networks, repeat the unnecessary panic that we have previously experienced. The coronavirus identified in China in 2019 caused nothing less than a strong cold or flu, with no difference so far with cold or flu as we know. Respiratory viral conditions are numerous and are caused by several viral families and species, among which the respiratory syncytial virus, especially in infants, influenza, human metapneumoviruses, adenoviruses, rhinoviruses, and various coronaviruses, already described years ago. It is striking that earlier this year, global health alerts have been triggered as a result of infections by a coronavirus detected in China, COVID-19, knowing that each year there are 3 million newborns who die in the world of pneumonia and 50,000 adults in the United States for the same cause, without alarms being issued. Our planet is a victim of a new sociological phenomenon, scientific media harassment, triggered by experts only on the basis of laboratory molecular diagnostic analysis results. Communiques issued from China and Geneva were replicated without being confronted from a critical point of view, and above all, without stressing that coronaviruses have always infected humans and always cause diarrhea and what people call a banal cold or common cold. Absurd forecasts were extrapolated, as in 2009 with the H1N1 influenza virus. There is no evidence to show that the 2019 coronavirus is more lethal than respiratory, adenoviruses, influenza viruses, coronaviruses from previous years, or rhinoviruses responsible for the common cold. Dr. Eran Ben David and Dr. J. Bhattacharya are professors of medicine and public health at Stanford University. Here's what they say. Projections of the death toll could plausibly be orders of magnitude too high. The true fatality rate is the portion of those infected who die, not the deaths from identified positive cases. The latter rate is misleading because of selection bias in testing. The degree of bias is uncertain because available data are limited, but it could make the difference between an epidemic that kills 20,000 and one that kills 2 million. A universal quarantine may not be worth the cost it imposes on the economy, community, and individual mental and physical health. We should undertake immediate steps to evaluate the empirical basis of the current lockdowns. Dr. Tom Jefferson is a British epidemiologist based in Rome. He works for the Cochrane Collaboration, where he is an author and editor of the Cochrane Collaboration's Acute Respiratory Infections Group, as well as part of 4 other Cochrane groups. He is also an advisor to the Italian National Agency for Regional Health Services. And here's what he says. So I cannot answer my nagging doubts. There does not seem to be anything special about this particular epidemic of influenza-like illness. There are, however, 2 consequences of this situation that bother me. The first is the lack of institutional credibility as perceived by my friends. They range from firefighters, policemen, and even a GP. Not the kind of people you would want to alienate in an emergency. A restaurant owner told me he would never report himself to the health authority, as that would mean at least 2 weeks of closure and his business would go to the wall. The second is that once the limelight has moved on, will there be a serious and concentrated international effort to understand the causes and origins of influenza-like illnesses and the life cycle of its agents? Past form tells me not, and we will go back to pushing influenza as a universal plague under the roof of the hothouse of commercial interests. Note the difference. Influenza, caused by influenza A and B viruses, for which we have licensed vaccines and drugs, not influenza-like illnesses, against which we should wash our hands all year round, not just now. Meanwhile, I still cannot answer Mario's question, what's different this time? This is from the British Medical Journal in March 2020. Dr. Michael Levitt is professor of biochemistry at Stanford University. He is a fellow of the Royal Society, a member of the National Academy of Sciences, and received the 2013 Nobel Prize in Chemistry for the development of multi-scale models for complex chemical systems. In February this year, he correctly modeled that the China outbreak was coming to an end, predicting around 80,000 cases and 3,250 deaths. Here's what he says. I don't believe the numbers in Israel, not because they're made up, but because the definition of a case in Israel keeps changing, and it's hard to evaluate the numbers that way. There is a lot of unjustified panic in Israel. I don't believe the numbers here. Everything is politics, not math. I will be surprised if number of deaths in Israel surpasses 10, and even 5 now with the restrictions. To put things in proportion, the number of deaths of coronavirus in Italy is 10% of the number of deaths of influenza in the country between 2016 and 2017. Even in China, it's hard to look at the number of patients because the definition of patient varies. So I look at number of deaths. In Israel, there are none. So that's why it's not even on the world map for the disease. That is from the Jerusalem Post, 20th of March, 2020. And again here, Levitt analyzed data from 78 countries that reported more than 50 new cases of COVID-19 every day and sees signs of recovery in many of them. He is not focusing on the total number of cases in a country, but on the number of new cases identified every day, and especially on the change in that number from one day to the next. Numbers are still noisy, but there are clear signs of slowed growth. What we need is to control the panic, he said. In the grand scheme, we're going to be fine. It's from 22nd of March. German Network for Evidence-Based Medicine is an association of German scientists, researchers, and medical professionals. The network was founded in 2000 to disseminate and further develop concepts and methods of evidence-based and patient-oriented medicine in practice, teaching, and research, and today has around 1,000 members. What they say. In the majority of cases, COVID-19 takes the form of a mild cold or is even symptom-free. Therefore, it is highly unlikely that all cases of infection are recorded, in contrast with the deaths which are almost completely recorded. This leads to an overestimation of the CFR. According to a study of 565 Japanese people evacuated from Wuhan, all of whom were tested, regardless of symptoms, only 9.2% of infected people were detected with currently used symptom-oriented COVID-19 monitoring. This would mean that the number of infected people is likely to be about 10 times greater than the number of registered cases. The CFR would then only be about 1/10 of that currently measured. Others assume an even higher number of unreported cases, which would further reduce the CFR. The widespread availability of SARS-CoV-2 tests is limited. In the USA, for example, an adequate state-funded testing facility for all suspected cases has only been available since March 11, 2020. In Germany as well, there were occasional bottlenecks which contribute to an overestimation of the CFR. As the disease spreads, it becomes increasingly difficult to identify a suspected source of infection. As a result, common colds in people who unknowingly had contact with a COVID-19 patient are not necessarily associated with COVID-19, and those affected do not go to the doctor at all. An overestimation of the CFR also occurs when a deceased person is found to have been infected with SARS-CoV-2, but this was not the cause of death. The CFR of 0.2%, currently measured for Germany, is below the Robert Koch Institute's calculated influenza CFRs of 0.5% in 2017-2018 and 0.4% in 2018-2019, but above the widely accepted figure of 0.1%, for which there is no reliable evidence. Beyond the rather questionable conclusions drawn from the historical example, there is little evidence that NPIs for COVID-19 actually lead to a reduction in overall mortality. A Cochrane review from 2011 found no robust evidence for the effectiveness of border control screenings or social distancing. A systematic review from 2015 found moderate evidence that school closures delay the spread of an influenza epidemic, but at a high cost. Isolation at home slows down the spread of influenza, but leads to increased infection of family members. It is questionable whether these findings can be transferred from influenza to COVID-19. It is completely unclear how long the MPIs must be maintained and what effects could be achieved depending on their duration and intensity. The number of deaths might only be postponed to a later point in time without any change in the total number. Many questions remain unanswered. On the one hand, the media confronts us daily with alarming reports of an exponentially increasing number of ill and dead people worldwide. On the other hand, the media coverage in no way considers our required criteria for evidence-based risk communication. The media is currently communicating raw data. For example, there have been X infected persons and Y deaths to date. However, this presentation fails to distinguish between diagnoses and infections. And we'll end with Dr. Richard Chavas. He is the former Chief Medical Officer of Ontario, Medical Officer of Hastings and Prince Edward Public Health, and Chief of Staff at York Central Hospital. Here's what he says. Far more cases are out there than are being reported. This is because many cases have no symptoms and testing capacity has been limited. There have been about 100,000 cases reported to date, but if we extrapolate from the number of reported deaths and a presumed case fatality rate of 0.5%, the real number is probably closer to 2 million. The vast majority mild or asymptomatic. Likewise, the actual rate of new cases is probably at least 10,000 a day. If these numbers sound large, though, remember that the world is a very big place. From a global perspective, these numbers are very small. Second, the Hubei outbreak, by far the largest and a kind of worst-case scenario, appears to be winding down. How bad was it? Well, the number of deaths was comparable to an average influenza season. That's not nothing, but it's not catastrophic either. And it isn't likely to overwhelm a competent healthcare system. Not even close. I am not preaching complacency. This disease is not going away anytime soon. We should expect more cases and more local outbreaks, and COVID-19 still has the potential to become a major global health problem with an overall burden comparable to that of influenza. We need to be vigilant in our surveillance, but we also need to be sensible. Quarantine belongs back to the Middle Ages. Save your masks for robbing banks. Stay calm and carry on. Let's not make our attempted cures worse than the disease. I hope this information has been helpful, and please subscribe and share with anyone who you think will benefit, and have a great day.